Welcome to Falling Through the Cracks. Feel alive and thrive with Dr. Rebecca Risk. Do you ever feel that even though nothing seems seriously wrong and you pass all the medical tests, that you still feel that your health, pain, and fatigue are completely out of control? It doesn't have to be that way. Listen to the tips and suggestions given on our program today and take back control of your health. Now, here is Dr. Rebecca Risk.
Hi, everybody. Welcome to Falling Through the Cracks. Joining me today from Toronto is Raisa Deber. She's a professor, and her current research centers on Canadian health policy. We're discussing her book, Treating Healthcare, How the Canadian System Works and How It Could Work Better. Raisa, welcome to the show.
Thank you.
So what inspired you to put this book together?
Actually, I was asked to write the book by University of Toronto Press. They have something called an Insight series, which is trying to give information about topics to intelligent general readers that don't necessarily have a background in it. And I have a book called Case Studies in Canadian Health Policy and Management that was done with the students who take my course. And there's an intro chapter in it which sort of gives a whole bunch of concepts. And it had been going over well enough that U of T Press asked if I would be willing to write a book for the Insight series. So,
it seems like a pretty important topic to me, especially since I talk about health and that kind of thing. I mean, the Canadian healthcare system is always a topic of conversation in Canada. Is it good? Does it need work? How does it work? That kind of thing. So I think we'll just start with what exactly is health policy? What does that mean?
Well, it depends on who you are and how wide you want to get on it. Because if you get into things like determinants of health and the things that help keep you healthy, that's everything. It's the air you breathe, whether you're wearing seat belts, the water you drink, the food you eat, your social supports. So you could go everything from health just being sickness care and taking care of you when you get sick to a whole look about how do you keep you healthy in the first place. So it depends on who you're talking to in terms of what you're going to call part of healthcare.
Well, and I thought it was interesting that you brought up that our healthcare system really is sickness care. Can you just tell us what the difference would be between something that isn't sickness care and what sickness care really means in your book?
Yeah, well, I think what I was trying to do in the book is I was not trying to write an advocacy piece. I was trying to give information. One of the things that I've been teaching here for longer than I want to think, but one of the things that was always clear is I said, I can't tell you what you should want. What I can do as a scholar is try to help say whether particular things will or won't work to take you there. So if you take a look at the population, most of the healthcare expenditures are for a very small number of really sick people. Because most of us, fortunately, don't need a lot of health care, and as long as you're pretty healthy, it's not an issue. But if you're unlucky enough to get cancer or get some awful condition, then all of a sudden it can become very expensive. So what the sickness care is what happens when you actually get sick. And then there's a whole lot of other things about how do you keep you from getting sick in the first place, if that's possible.
Well, and there seems to be less focus on that from my point of view, and I don't know if that's the people out there are just not interested, or if it's not available to us. But I feel like a lot of people are using the system only when they're sick. So, some people tell me, I haven't been to my doctor in 5 years, and all of a sudden I have to go all the time. And even the follow-up visits are important when you feel well. But it seems like that doesn't happen all the time.
Well, it depends. If you've got a good family doctor, it's a balancing act. You don't want to get care you don't need. You don't need to go to the doctor just to go to the doctor.
Yes.
So things like, okay, let's make sure your blood pressure is okay. Let's make sure other things. But we have all kinds of things, but public health is a key piece of the picture. And one of the things they say in public health is if it's successful, it's invisible. I mean, look at the few examples we've had of people getting poisoned by polluted water. Mm-hmm. And as long as the water is properly treated and cared for, this doesn't become an issue. So, one of the cases in my casebook is Walkerton, or you have Flint, Michigan, or you have other things like that, where all of a sudden you're getting sick because people haven't been taking proper care of the water. But if it's done right, we don't notice that. Same thing with air quality. There are certainly places where you have a lot of problems because the air is so polluted that you have problems breathing it. Most of the time, this isn't an issue. So, it's not that you don't pay attention to it. If same thing, if you're homeless, you're clearly going to have a lot more problems than if you've got a roof over your head and you have meals to eat. So, there's all kinds of things we take a look at that are not sickness care, that are preventive, but they're not part of the healthcare system.
So, what would be healthcare then?
Well, healthcare is the sorts of things given by people who are called healthcare workers, by doctors, nurses, social workers, physiotherapists in hospitals, in clinics, doctors' offices. That's the part that's healthcare. And it's extremely important, particularly if you're unlucky enough to be sick, but it's not the whole picture.
So what's the whole picture?
Well, the whole picture is basically what our society looks like. Yeah. So it's like how do we keep people healthier? And there's all kinds of things. If you take a look at the World Health Organization's definition of health, it's a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So did your hockey team win a big game? Was that going to make you healthier? I don't think most people would say hockey players count as part of the healthcare system.
So, well, that's an interesting way to put it, though, because the emphasis isn't always on that entire definition. I mean, most people just look at their physical well-being. Are they in pain? Are they tired? Et cetera. And they're not looking at the social aspect. And there isn't a lot of emphasis on that either. We're kind of, left to our own devices in that, which does make sense in a way. But also, if that's part of healthcare, part of our health, not part of healthcare, something might need to shift.
We're not left to our own devices about getting clean water or having the air quality decent.
No, that's true.
For some things, we're left to our own devices, but for a lot of things, no. We are working together as a society. Mm-hmm. What about educating kids, having reasonable schools? So on something, and then it depends on where you are about what sort of social supports. So what do we do to make sure that kids have meals? So some places have school lunch programs. So it's incredibly variable about how much we do as a society, but certainly a whole lot of the social determinants of health, particularly the environment, is definitely done as a society.
Mm-hmm, for sure. And a lot more emphasis on that these days, for sure.
Yeah.
Yeah.
I've had friends who are living in, working in countries where they don't pay that attention, and they wanted to get out because they were afraid of what would happen to their kids given the air they had to breathe.
Yes, definitely. Well, and that's definitely a movement happening worldwide, but it does take time, and I think it's something that we pay a lot of attention to, seems.
Yeah.
Yeah. So our Canadian healthcare does stand out. It's a little bit different than, our neighbors in the United States were a very large contrast with them. Can you just explain how we're different from the American system and what makes us stand out?
Well, one of the neat things is you take a look at the United States, they make every country look good. I mean, every time you say, there's some problems with our system, you then just look down at the U.S. and you say, we're not nearly as bad as the U.S. The U.S. spends way more than any other country, much of it public. In fact, they spend as much as Canada does publicly to have more people without coverage than the entire population of Canada and worse outcomes.
So,
okay.
Yeah.
And part of the thing is this myth that it should be competition and private and that you do it that way. And I said that most of us are pretty healthy and most of the health costs are a small number of sick people. So if you have a competitive insurance market, the best way to make money is not to cover sick people. And then you can make a load of money charging relatively healthy people. They don't need a lot of care. They don't use a lot of care. And then the sick people are on their own.
Which doesn't sound like we're addressing the society part of health.
Or
they are not addressing
or the individual part. I mean,
yeah.
I have a friend who was in the States, was working for a small tech startup company, and he had a child with a genetic disease. So they fired him so they wouldn't have to pay for the child's health care costs out of their health insurance.
I didn't know that they could do that.
Oh, yeah, and what you start getting into is for a lot of these childhood genetic diseases, the life expectancy is way less in the United States than it is in Canada because the kids can't get coverage, and they don't get the care they need.
Yeah. Well, we have our complaints in Canada, but, when you look at situations like that, or you hear stories about people going bankrupt because they had cancer, we do, and I do think we take for granted what we have here, what we have offered to us, that, when you are sick, you can go to the doctor even if you don't have money in the bank, and you can get help.
Yeah. I mean, there's certainly gaps, and there's certainly ways we can improve it. But, yeah, and the other thing that I think is important, we keep talking about Canada. As you know, Canada does not have responsibility for health care because when the BNA Act was put together in 1867, there just wasn't a whole lot that was being done. So the BNA Act gave responsibility for health care to the provinces and territories. So the feds can provide some money, but the systems themselves are up to the provinces and territories to decide how they want to manage them. So you are going to get variability depending on where you happen to be. Yeah,
and so how does that vary province to province then? If we all have socialized health care, but what does that look like across the board then if it is regulated differently?
Well, it's not even regulated differently. What it is it sets a minimum, because what happened is that Canada initially started by, it was started with Saskatchewan, saying that what we're going to do is we're going to start insuring hospital services. So the federal government got into the act to say, okay, if you want to set up a insurance plan, we'll pay some of the cost. And the provinces all got in because they didn't see the point of saying, your money is going to go to help pay for insurance for people in Saskatchewan, but not for people in our province. So what happened is by 71 or so, every province had full coverage for hospital care and physician care because they started with the most expensive pieces. And then the model that they had, federal money only went for hospital care or physician care. So you had a randomized trial of nurse practitioners in Ontario, and they worked beautifully, but it didn't go anywhere because you would get no federal money unless the patient was seen by a doctor. So what they did is they changed the model, and they said, okay, no, we'll give you some block money going into provincial general revenue. But then they had to put some rules saying, what do you need to do to get the money? So what the Canada Health Act, and it's been since 1984, so what the Canada Health Act says is, look, if you want federal money, you have to give full coverage with no co-pays for all physician services and hospital services. You can go beyond it, but you don't have to. So provinces vary a lot because let's say I'm in the hospital. My drugs have to be paid for, my rehab has to be paid for. The minute you send me home, you still have to pay for the doctor visits, but everything else you don't have to pay for. But it may be very penny-wise, pound-foolish not to. So some provinces will pay for your outpatient drugs, or some drugs, others won't. Some will pay for outpatient rehab, others won't. There's variability in what they'll pay for home care or long-term care. So you're going to see a lot of difference depending on where you are about what sorts of things are or are not picked up by the provincial plan and for who.
So, right now, we do have this full socialized system that looks like that. It is a little bit different everywhere, and I do think that
it's actually on the low end. About 70% of Canadian healthcare costs is paid for publicly.
Okay, and so how does that work?
Well, just that. Just about all the doctor costs and most of the hospital costs, except for things like capital and that, are paid for publicly. But there's a lot of variability in the rehab, the drugs. Dental care is almost entirely private. Vision care is almost entirely private. Mm-hmm. So it very much depends on what you're talking about. Mental health is a big problem because the coverage, mental health back in the day, the assumption was you would be in a provincial psychiatric hospital. Mm-hmm. That's not how it's done now. So again, you've got a lot of variability in what sort of coverage you get for mental health.
Yes, because if you just want to see a counselor, you pay out of pocket for that most of the time. Yeah, which is difficult because most people are experiencing mental health issues at some point in their life, and not everybody can afford the help that they need.
Exactly. So that there are, in terms of pieces that I think we need to do something about, mental health is a big one.
Yeah, I definitely agree. We're going to take a quick break. We're talking today with Raisa Deber, and she's a professor at the University of Toronto. We're discussing her book, Treating Healthcare, and we'll be back shortly.
Are you finding your frequency? It can be described as that space between failure and success. It's the future of digital media. It's finding your voice. It's engaging topics, content, and ideas. Jeff and Ryan discuss the digital media space and all of its aspects. It's about making the mistakes, taking the chances, summoning the intestinal fortitude to step out of your comfort zone, and discovering what you can accomplish when you decide to try, decide to learn, decide that you have something to say, and find your frequency. Live Fridays at 2 p.m. Pacific Time, 5 p.m. Eastern Time on the Voice America Variety Channel.
Everything is energy. It's all connected. Your energy can be seen as the foundation for your life and impacts all areas of living. Do you realize that your thoughts have the power to affect how you show up? Tune in for Healthy Energy with Margot, featuring host Margot Nielsen. Margot and her guests will show you that connecting to your energy is vital to your health, relationships, money, and more. Listen live every Monday at 12 noon Pacific Time, 3 p.m. Eastern Time on the Voice America Health and Wellness Channel. When a woman is diagnosed with breast cancer, it's probably the most frightening thing that's ever happened to her. Friends and family often don't know what to do for support, not to mention the patient herself. That's where Breast Friends Cancer Support Radio comes in. Join Becky Olson and Sharon Hennepin, breast cancer survivors and advocates. They help by providing inspiration, information, and most of all, hope. Tune in Wednesdays at 9 a.m. Pacific Time, 12 noon Eastern Time on the Voice America Health and Wellness Channel, and Thursdays at 9 a.m. Pacific Time on the Voice America Women's Channel.
Have you friended us on Facebook yet? Why not? Just go to facebook.com/Voice America or search for the keywords Voice America. Once you are part of our Facebook network, you'll receive daily messages about what's happening with our shows, this week's featured guests, and new happenings at the Voice America Talk Radio Network. And you can add your voice to the always active discussions on our timeline. Just go to facebook.com/Voice America or search for Voice America.
You are listening to Falling Through the Cracks with your host, Dr. Rebecca Risk. To reach the program today, please call in to 1-866-472-5792. Again, that's 1-866-472-5792. You may also send an email directly to Dr. Risk. The email address is anantacalgary@gmail.com. Now, back to Falling Through the Cracks. Feel alive and thrive.
Hi, everybody. Welcome back. We're talking to Raisa Deber, and she's a professor at the University of Toronto, and we're discussing her book, Treating Healthcare. So, Raisa, one thing I want to talk about is actually the history of our healthcare. I'm from Saskatchewan, which is where this originated. So I grew up mostly in Saskatchewan, but we always learned that this is where it started. Can you just tell us how we got to the point where we have this socialized system?
Yeah, well, be careful is not a socialized system. What it is a single-payer system with universal coverage. If you make a distinction between how healthcare is financed and how healthcare is delivered, the people who deliver healthcare are not civil servants. Doctors do not work for the government. Someone working in a hospital is not like a public school teacher. Now, it's a little closer, actually, in Alberta than in many because you did get rid of local hospital boards. In Ontario, we've still got local hospital boards, and, they're independent providers. They just happen to be paid by one insurer.
Okay.
And what they realized in Saskatchewan is that you will save a mint. You can give better care for less money if you have a single payer. And it's better for just about everybody because if I'm a hospital, I don't have to have a whole bunch of people who can figure out, they say, okay, what's your insurer, and know how to fill out their forms and do everything else. I mean, look at what poor dentists have to go through in terms of trying to figure out what the coverage is and all of the different plans and all of the different rules. So if you look in the U.S., they have to spend an enormous amount of time and effort figuring out what the insurers, and then if you don't have insurance, and they'll give care for you anyway, they end up with a bad debt. So what they realized in Saskatchewan is that if you gave everybody coverage, you wouldn't have a situation where the providers have bad debts. You would save a lot on your overhead costs, and you could get better results. And you wouldn't have people waiting until they had a heart attack before seeing the doctor, because if this was something where earlier care could make a difference, you could do that. So what Saskatchewan realized is a universal insurer with a single payer would make a lot of sense. And then the rest of the country followed along.
So how long did that take us to implement this?
Oh, I think it depends on what you're defining by implement. And I'm not a great expert on the exact pieces of the history and how it went in. But, and if you want, Greg Marshallton has written some good stuff on that, and I can refer to a lot of Greg's work. But certainly it sort of started in the 50s, and by 1971 we were pretty well there, although there's a whole lot of other little things that we really can and should change.
And
I'm looking in my book to try to see if I actually put in any of that. And I've got a little bit about that in there, but yeah. Anyway.
So when we're looking at, we compared ourselves to the United States, which I think, everybody understands what their model is and those issues. But how do we compare to the rest of the world?
Well, the interesting thing to look at is the U.S. actually has some pieces of the system that is very much like Canada. They have what they call Medicare. They have what they call Medicaid, which is if you're over 65 or if you're poor, you are eligible. There is a single payer. And it's exactly the same thing. Individual providers will just bill the single payer. So the U.S. does have a Canadian piece in it for a certain chunk of the population.
And yeah.
But there's a number of different models, and I think there's no one right model. Everybody's got pieces of it that work pretty well and work pretty badly. And in the book, I actually have some of the comparative OECD data. And one of the things that's important to recognize is that on some metrics, the results are pretty close to each other, and therefore pretty small changes in absolute numbers can make big differences in your absolute rank. Okay?
Mm-hmm.
Like, for example, life expectancy at birth for males in 2014. The average from the OECD countries was 77.9. But the highest scoring country was 81.3, and the lowest was 69.1. So Canada, which is above the average, at 79.4, ranked 14th. And Germany, which was 78.7, ranked 21st. Okay? So tiny changes in the numbers can make pretty big changes in some of the rankings. And that's the thing that's important to recognize is when you're doing the comparisons, what are you comparing and what difference does it make to how people do?
Mm-hmm.
So I think we're pretty well in the midpoint. You know, there's some things we look better on, some things we look worse on, but there's no chunks where we look really awful. And then one of the other differences, are we talking urban areas or rural areas? Because if you're in the middle of a big city, it's easy to get specialized care. If you're in a more rural, remote area, you may have to travel a lot more to get specialized care. And then here's one of the Canadian complexities, which is it's hard to do e-health. And because you have to be licensed in each province you're giving care to. So if you tried to set up something in Calgary to deliver care to Northwest Territories, Manitoba, et cetera, every physician working there would have to be licensed to practice in each province territory that they were giving care to. So, you know, again, because back when we set these rules up, around the world in 80 days was considered an achievement.
Yeah.
So, you know, this assumption, this recognition that things can travel a lot faster becomes tricky. It's the same thing as the epidemics. The quarantine stops the minute you come into the country. So if you look at something like SARS, the minute somebody with SARS is in the country, they become a provincial territorial responsibility. So how do you stop spread of the epidemic? And we didn't have the mechanisms in place to do it very well because the assumption was it was all being done locally.
So, and that's obviously something that, I mean, you're right, when travel was harder is when this was set up. And it's a lot easier now. And, you know, people move around a lot more than they used to as well. And I know, you know, one issue is that you go even, it's not just when doctors go to another province, they can't practice, but when we go to another province, you know, it takes 3 months to get health care. And some people do feel a little trapped by that.
Well, it's not. It doesn't take through. This is the portability requirement of the Canada Health Act, which is what do you do if healthcare is a provincial thing and your plan is provincial? What do you do if you get sick in a different province? And so what they said is, look, for the first 3 months, you're the responsibility of your home province, and then after that, you're deemed to have moved. Although you have to go through the paperwork and make sure you're registered where you moved to. So the idea was if you're gone skiing in Whistler and you break your leg, who should have to pay for the care? Mm-hmm. Okay, but it becomes very problematic. What if I'm a student? So I'm studying at Dalhousie, but I'm not from Nova Scotia. Who's responsible for my care? How do you do it? What if I'm a foreign student? And so you get into all of these complexity. What if I'm an immigrant? So you don't have a home province. So that's what the 3 months was the minimum set. What if I'm living near Ottawa, but I'm on the Quebec side of the border, and my kid needs care from a children's hospital, but the children's hospital in Ottawa is Ontario, and if Quebec is willing to pay for that care, do I have to go down to Quebec City or Montreal every time my child needs care? So it becomes, you know, it can be worked out. And a number of the provinces have done that. I mean, PEI has arrangements with Nova Scotia for a lot of the specialized care because they know they're not big enough to set it up. So what do you do? But it's up to the individual. It's almost on a disease by disease, you know, case by case, area by area basis about how they've set it up.
Mm-hmm. Well, I had a friend that was going to move out of Alberta, and they sold their house, and the same month she got diagnosed with breast cancer. And they had to stay in Alberta for her treatment, and they had to rent somewhere and wait until she was clear. And because if they had moved, they would have had to wait for treatment, so they were told to stay.
Well, you see, it would have depended. If they had treatment and Alberta agreed to pay, it would not have been a problem.
Mm-hmm.
So this would have been more of a, how does Alberta link with the other provinces? What deals do they have? How do they do it? So it's not that it's not possible, but it's a whole bunch of individual province deals. So it would be a question of what the arrangement was that Alberta had with whatever province they were planning to move to.
Mm-hmm. Yeah, it sounds like it can get complicated, like in that case where, they had no home at that point as well. And so their plans had to change, and it's stories I've heard before. So it seems something. But
it also would have been whether or not their doctors could get her properly referred in and seen. So if they had linkages with the local doctors and hospitals, they could get care more easily than if they. So where were they planning to move to?
To Manitoba.
Okay, so it would have been a question of what the availability was of the services in Manitoba that they needed.
Mm-hmm. Yeah. Which so as you're saying, can be complicated too if it's not available to you right where you are. It does get a little tricky.
Yeah. So this is, what it is the care, when you come right down to it, is very much of a local thing of, who are the clinicians, what is the condition, what do you need, what's available where, how do you do it? And that's not a government thing. So, so much of it comes down to, we've got a really good family doctor. So if, God forbid, we need some sort of care, they can help arrange it. But one of the reasons they can help arrange it is that the other clinicians know that this practice doesn't send you for things that you don't need it.
Yes, exactly. So when we're looking at, this whole system, and, we did mention that mental health doesn't get paid for unless you're in an institution.
Or being seen by a doctor.
Yeah. How do we decide what does get paid for and what is in the scope of this whole system?
Yeah, and that's very much a thing that is decided by, it sort of depends on how much you decentralize it. So with hospitals, if they have global budgets, the hospitals decide what it is that they're going to be doing. Because you don't have a thing that every time a nurse takes your vital signs, she puts in a bill for that. Mm-hmm. So some of these are salaried and these are things that they do. Whereas if you're on a fee schedule, the issue becomes what's on the fee schedule and what are you paid for. So it's very much a thing about how is that organized, arranged, who makes decisions. So for certain things like drugs, you'll have some bodies that decide whether or not particular products are safe enough and effective enough to warrant being put on a formulary. And then does the hospital buy it? Or does the province have a drug plan? Will the drug plan pay for it? So it's incredibly decentralized in a lot of these situations, particularly if they're starting with a global budget.
Okay. We're going to take a quick break. We're talking today with Raisa Deber, and we're discussing her book, Treating Healthcare. We'll be back shortly.
Are you finding your frequency? It can be described as that space between failure and success. It's the future of digital media. It's finding your voice. It's engaging topics, content, and ideas. Jeff and Ryan discuss the digital media space and all of its aspects. It's about making the mistakes, taking the chances, summoning the intestinal fortitude to step out of your comfort zone, and discovering what you can accomplish when you decide to try, decide to learn, decide that you have something to say, and find your frequency. Live Fridays at 2 p.m. Pacific Time, 5 p.m. Eastern Time on the Voice America Variety Channel.
Everything is energy. It's all connected. Your energy can be seen as the foundation for your life and impacts all areas of living. Do you realize that your thoughts have the power to affect how you show up? Tune in for Healthy Energy with Margot, featuring host Margot Nielsen. Margot and her guests will show you that connecting to your energy is vital to your health, relationships, money, and more. Listen live every Monday at 12 noon Pacific Time, 3 p.m. Eastern Time on the Voice America Health and Wellness Channel. When a woman is diagnosed with breast cancer, it's probably the most frightening thing that's ever happened to her. Friends and family often don't know what to do for support, not to mention the patient herself. That's where Breast Friends Cancer Support Radio comes in. Join Becky Olson and Sharon Hennepin, breast cancer survivors and advocates. They help by providing inspiration, information, and most of all, hope. Tune in Wednesdays at 9 a.m. Pacific Time, 12 noon Eastern Time on the Voice America Health and Wellness Channel, and Thursdays at 9 a.m. Pacific Time on the Voice America Women's Channel.
Have you friended us on Facebook yet? Why not? Just go to facebook.com/Voice America or search for the keywords Voice America. Once you are part of our Facebook network, you'll receive daily messages about what's happening with our shows, this week's featured guests, and new happenings at the Voice America Talk Radio Network. And you can add your voice to the always active discussions on our timeline. Just go to facebook.com/Voice America or search for Voice America.
You are listening to Falling Through the Cracks with your host, Dr. Rebecca Risk. To reach the program today, please call in to 1-866-472-5792. Again, that's 1-866-472-5792. You may also send an email directly to Dr. Risk. The email address is anantacalgary@gmail.com. Now, back to Falling Through the Cracks. Feel alive and thrive.
Hi, everybody. Welcome back. Today we're talking with Raisa Deber. She's joining us from the University of Toronto, and we're discussing her book, Treating Healthcare, how the Canadian system works and how it could work better. So, Raisa, how could our system work better?
Well, I think one of the things is, there's a number of things that I had in the book. One is to make people healthier and help them stay healthy. A second is to improve how we coordinate services and improve the quality. The third is change how we organize our system, including revisiting how we pay for care, including who pays for what and how we deliver it, which is, the wait list access issue. And then the final one is get more efficient and get better value for money. So those were the four things that I suggested that might be helpful.
So let's start with the first one. How can we get people healthier and stay there?
Well, there's all kinds of things, making sure that, like when I was a kid, I never used to see homeless people, and now you see people sleeping on the street. I wouldn't think that's particularly good for them. Making sure that kids eat healthy food, making sure that we have, proper education, making sure that you can walk around. There's some, not Toronto, but there's some communities that you visit where you cannot walk because it's just highways and you can't cross the streets and you can't go anywhere. So there's all these complicated things about what do we do about determinants of health and how do we help people manage. Like if you got diabetes, how do you make sure that you keep it under control? How about keeping your blood pressure under control? Then there's the things about better integration so that you don't have a whole bunch of little silos that somebody falls between the cracks in terms of trying to keep the care put together. Then there's the, if I'm out of a hospital, what do you do about covering those things and handling that? And then there's a wonderful model called Choosing Wisely, which is focusing on let's not do things that don't make sense. So to spend money on care that you don't need and is not going to do you much good doesn't seem like a particularly good use of anybody's money. Mm-hmm. So how do you work out a model that you're taking care, you're doing the things that make sense and you're not doing the things that don't make sense?
Yeah, but which is tricky because not everybody, like, are you talking about a model for doctors to follow for doing tests, or a bigger model?
This is all being done by the doctors, and they're coming up with a number of different approaches, which say, okay, these are particular tests that are being overused. Let's stop overusing them. These are the times under which it does make sense to do it. These are the times where it doesn't. So you have a lot of effort to try to see what you can do to try to improve the quality of care. And as I said, this is being led by physicians, and I think they're doing a brilliant job with it.
Mm-hmm. How can we improve services?
Well, I think it's not going to be a one-size-fits-all.
Mm-hmm.
There's going to be a number of things where you can figure out how to do it more effectively. There's certain, like, it's never struck me as making a lot of sense to have somebody have a heart attack because they couldn't afford the medication to keep their blood pressure under control.
Mm-hmm.
And so another of the things is what are we paying for things? Because it's not just what are you doing, it's what are you paying for it. So prescription drugs, if we have joint purchasing, could we get the costs down? If we have a lot more looking at what's the value added of particular drugs, because there's these incredibly expensive drugs, and some sort of scrutiny about when does it make sense, when doesn't it make sense.
Mm-hmm.
So it's not a one-size-fits-all. There's a whole lot of little things, each of which could, and in the best case, you have a win-win, which is you spend less money and you get better outcomes.
And so, what would that? I mean, there's probably a lot of things, but what would this look like if there's just an example of improving services? So would that be like on the part of in hospitals, or would that be the part of seeing your family doctor, or is there a broader spectrum you're looking at?
It's not an or. It's basically how do you make sure that the hospital works together with the family doctor, works together with others, and it's what are you talking about? Are you talking acute conditions? Are you talking chronic conditions? Are you talking about working with the caregivers to make sure that people with chronic conditions get the care that they need? So it's going to be very individualized to what's the sort of condition, what's the best practices right now, how do you do it in a way that's going to work?
Mm-hmm.
And, which means it's never going to be over. You're not going to be able to say, okay, I've done this and now it's done, because new treatments are always coming along, new things are always happening. But it's making sure that people can work together. And the advantage that we've got is most of the clinicians I know are very motivated by trying to make sure that people get the best care that they can. So since they're motivated by that, they're not going to give you a whole bunch of unnecessary visits simply because they get money for each one of them. So I'm not usually worried that somebody's going to try to give me open heart surgery I don't need simply because they're going to make a buck out of it.
Mm-hmm.
So we rely very heavily on the fact that most of the people in the field are ethical and they're there because they want to help. But there's a whole lot of things that we could do to try to make it better. And in the ideal situation, you save money. The thing that you don't want to do is start going to private financing, because all that happens in that is the costs go up and the equity goes down. It's a lose-lose.
Yeah, so that's one thing that gets talked about. It comes and goes as an issue, and some people are an advocate for that. And I think that might come from the long waits, when you're in pain and you have to wait 6 to 12 months for an MRI or a specialist or whatever is going on. And so some people do talk about having a private system so that you don't have to do that. And so what would be the drawbacks to implementing something like that?
Okay, the big drawback is, why would you pay less? You had a long wait, and what you could get in the publicly paid system is worse. So every place that's tried to do this public-private tier has found that what you get in the public gets worse, because otherwise there's no market for the private pay. So it's sort of a lose-lose. So if you're having to wait, figure out why and do something about the wait lists. I know some people who are industrial engineers, and they've done wonderful work applying engineering techniques to see what they can do to reduce wait lists. And in a number of cases, you do some efficiency, Like there was one hospital that was finding they didn't have enough recovery rooms. And then they looked and said, because you're starting all your surgeries at the same time. So they staggered the start time of the surgeries, and they had enough recovery rooms. So a certain amount of this just using engineering to look at how do we design same thing with wait lists. If you have a whole bunch of individual wait lists, then if one slot doesn't get filled, it's gone forever. Whereas if you have a unified wait list, then you're using all your time more efficiently. So there's a whole lot of things that you can do rather than say, you're going to have to wait 10 months. No. If you need it now, you should get it now. And let's figure out how come you're not and how to fix it.
Mm-hmm. Yeah, because that's still the case. I don't know about Ontario, but in Alberta, people do wait an average of 6 to 12 months for a specialist, usually on the longer side. And even for testing that they need, like let's say they need an MRI, it will still take that long. And
you have to be careful about how you measure that, because I know somebody who had cataract surgery. And the initial visit they had said, you are going to need it, but you don't need it yet. And about 4 years later, it got to the point where, they needed it, and they had it quite quickly. But by the way we measure wait lists, they were on the wait list for 4 years.
Okay.
Okay? So you have to be careful as to what the wait list means, because sometimes if they put you on because you are going to need it, but you don't need it yet. Hip and knees, you don't want to do it too quickly because there's a limited lifespan to them, and the revisions don't do as well as the first one. So it's this trade-off, and most of the data that I've seen, the things which are really life and death thing, the wait lists have gotten way better and are doing quite well. So you have to be careful that you know how you're measuring them.
Well, which is fair. I understand that. I mean, you've got to delay, surgery on your knees or whatever it is because they don't last. And you'll have to do it again. So you wait until you are at that point where it's, very necessary. But at the same time, I know a lot of people feel like their quality of life is on hold because they're waiting for an MRI for an answer. And I know lots of people that will spend, I think it's $700 or $800 for an MRI in Calgary because they don't want to wait and they want the answer of what's going on.
And I think that in that case, what they should do is figure out how come you're having so much weight and how to fix it up.
Mm-hmm. Yeah, that's definitely, I think that needs to be addressed because if you're in pain, which is usually what people are doing there, your quality of life is on hold. There's a lot of things you can't do and you don't know why. You're waiting to find out why, which is a very difficult situation to be in. It can cause a lot of problems down the road just because of the emotional impact and being in pain for that long.
Yeah, and that's the thing of figuring out why that is happening that way and how do you work it out so people don't need to do that. And absolutely. But having the private tier only for the people who are willing to pay is, in my view, not the way to go. What is the way to go is to figure out what's going on, why, and how do you fix it.
Mm-hmm. Yeah, because it's hard. Like, going back to that, a lot of people will look at, in the States, although they're paying, they don't have to wait. And, you can see a specialist and you can get a second opinion and you're not waiting 6 months in between to see people.
But that's because the people who can't pay are not getting it at all.
Yeah, which is also difficult because we don't want that either. We want everybody to be included.
Yeah, and there's no market for paying unless you're making people wait.
Mm-hmm. Well,
so that's the reason why most of the people who looked at it said this is a really bad idea because the wait lists get worse in order that some people are willing to pay to jump the line.
Yeah.
And I'd rather make sure that two things, I don't want to be in a line I don't need to be in. Mm-hmm. Okay, if I don't need that image, I don't want to get it. And if I do need it, I want to get it in a way that I need it.
Yeah, well, you pointed out in your book that it isn't saving the system, because some people think, oh, well, then we'll have lesser waits in hospitals. But what you're doing is redistributing the money, because people are leaving the system, but then the payment isn't there for what they're doing. So there's less money for other people who are utilizing the system, which still puts us in the same situation and may make it worse. Yeah.
And your total costs are higher, not lower. And so let's say I'm a company that is paying for people's insurance for my workers. It costs them a mint if you do it this way. So what you're doing is you're putting a burden on employers and making us less competitive economically.
Yeah. Yeah. So the fourth point is how to make things more efficient, which would solve the wait list. So how can we do that?
There's all kinds of ways to do that. The single queue, the looking and seeing, okay, what services do you need? Which services do you not need? There's a whole bunch of ways that it can be done, and they're actually doing a pretty good job of it from what I can see. The wait lists are now much less than they were, and they seem to be quite successful in a lot of this. So, I think, what you have to figure out is what do people need and how do you do it in a way that you get the care that you need when you need it of high quality. And I can't give you a one-size-fits-all answer because it's going to very much depend on what sort of service you're talking about, who's getting it, when, where, why. But I don't want services I don't need. There's no particular advantage to me out of having surgery that I don't need.
Definitely agreed. So, do you have any last comments for this topic before we end our show?
Oh, yeah, and tell people that my book is something that absolutely, they want to read. Okay, yeah.
Yeah, of course. So how can people get a hold of you or your book if they have more questions?
It's. I think it's available on Amazon. It's University of Toronto Press. You can also ask your local library if they want to get a copy, because certainly the library here has some. And but it should be relatively easy to get a copy, and we try to keep it cheap because we wanted people to be able to afford it.
Yeah, and
so
it was
not a super expensive book.
No, and it was an easy read, which I think is important because this is a topic that I think everybody in Canada should understand. And when it's not easy to read and we're using all this terminology, it's harder for people to understand what the issues are and how they can work to address it or talk about it with people.
Yeah. Well, one of the advantages is I had a number of friends of mine who are very smart people but are not in the field read it to try to pick up where was I using jargon that people just wouldn't know what the jargon was. So they were incredibly useful to me in pointing out examples of where I was using terms that to me were obvious, but they weren't obvious to people who were not in the field.
Right, which is important if we're trying to reach everybody. So thank you for doing that. I think, this is an important topic and something that we'll probably always be talking about, because how could we not want to make it better all the time, especially when it is life or death in a lot of situations.
Yeah.
So, thank you for joining me today and sharing this information. I appreciate it.
Oh, you're welcome.
Today we were talking with Raisa Deber. She was joining us from the University of Toronto, and we were discussing her book, Treating Healthcare, How the Canadian Health System Works and How It Could Work Better. And if you want more information about my story, about what I went through in my health journey, you can see that on my blog site at dr-risk.com. Don't forget to follow me on Twitter, Facebook, or Instagram. And thank you so much for listening today. Be sure to make today a great day.
Thank Thank you for tuning in to this week's edition of Falling Through the Cracks. Feel alive and thrive. Please join Dr. Rebecca Risk again next Monday at noon Eastern Time and 9 a.m. Pacific Time on the Voice America Health and Wellness channel. We'll talk more next week.